using health IT. But I'm here, I'm CJ Kunnappilly, I'm the Chief Medical Officer for San Mateo Medical Center. And I'm being punished because my slides are not coming up after that IT joke, but I'm sure they'll come up shortly. I'm here to talk about our ePrescribing journey, and I refer to this as a journey because, like any journey, you take some turns, you go up and down, you have some scheduled breaks, and then every once in a while, you have some unscheduled breaks because somebody in your party says, I need to stop now, and unless you want to mess, you're going to take a break. And so that was our journey through ePrescribing. A little bit about us. We're the county hospital and affiliated clinics for San Mateo County. We live within the San Mateo Health System, which is also the health department and a variety of other divisions in San Mateo County. We're an integrated healthcare delivery system, but the bulk of our work is really in ambulatory care. We do about 250,000 outpatient visits a year. And in a 10-month period between April of 2009 and February of 2010, we implemented a complete EHR. But I'm here to talk about electronic prescribing, and it's importantly linked because our EHR really started as a vision for electronic prescribing. It was based on a long history of outpatient focus on medication safety. We focused on adherence, on patient knowledge and communication around their medications. This had been going on for several years. We also had a history of innovation that we partnered with our performance improvement activities. We had a prior project that looked at the use of cell phones to promote asthma compliance. We'd also done flow redesign within our clinics and had piloted the use of registries. And so as we looked at our issues around outpatient medication safety, electronic prescribing became a natural fit. And our Vice President of Ambulatory Services at the time went out and started fundraising. And in a unique twist of fate, was much more successful than he ever expected. And we found that we could soon afford an EHR. And one of the issues, or several of the issues we were looking at were some of those issues that are unique to an integrated delivery system, one of which was that the specialists had their medication list, I as a primary care physician had mine, and a variety of other care providers throughout the organization had theirs, and they were rarely, if ever, integrated or consistent with one another. We also had issues around legibility for our prescriptions and issues around efficiency and whether patients could actually get their refills and their prescriptions when they needed them. So we had a few challenges as we set down along this path. One was, a little bit late in the game, we realized that there was a challenge inherent in trying to do electronic prescribing within an EHR. Initially, you sort of think that these are the same thing. They're one and the same. You get an EHR, you get electronic prescribing, you roll it all out together. They're very complex and different processes. And if you treat them as one rollout, it creates a lot of challenges. We also had the unique challenges around multiple stakeholders, and I think it's something that's ubiquitous to all forms of information exchange. With an EHR, you can at least fool yourself into thinking you have your hands around it, that it's all within your four walls and you can control all of the variables. When you start talking about electronic prescribing, you're dealing with external pharmacies, with external vendors, pass-throughs of information multiple times, and this becomes a significant challenge on top of an EHR rollout. There's also patient expectations, which was probably the thing that caught me a little bit off guard. I never expected patients to feel really uncomfortable leaving my office with nothing. On some level, I felt like they did that regularly. But when they knew that they had a prescription waiting and I hadn't actually handed them that prescription, it was a very disconcerting experience for them. Also, the difference between having employed physicians and contracted providers within our system. Employed physicians, we in primary care have a civil service model, and it was fairly easy to train everybody, get them up and running, and have them buy into the process. For our contracted physicians, there were a lot of other complications, including later we would find out the issue of having an outside practice that didn't e-prescribe would come back and bite us later in the process. And then the last thing, which at the time I did not appreciate because I wasn't fully vetted in IT, but I soon learned that the lack of a formal test environment had its issues. It is very difficult to understand how something is going to perform if you've never tested it before the first day you put it in the hands of your providers. So that was also a very interesting day. Many of these days were days when I reconsidered my position with the organization, but we got past that. As we got ePrescribing up and running, we actually were lucky enough to participate in a collaborative run by the California Healthcare Safety Net Institute focused on electronic prescribing. They provided us with technical support and really allowed us to create a sub-project around electronic prescribing as we continued with our EHR rollout. Within this process, we were able to identify both our internal and external stakeholders, including patients, outside pharmacies, SureScripts, RxHub, and to communicate with them in advance of actually rolling out ePrescribing. And because we had some areas of our system that were relatively closed, we were actually able to do some testing and understand how the process would work with our partner pharmacies. We also were able to use a rolling implementation so that we went from clinic to clinic, taking the learning from the prior clinic to the next one, and also a few people who had survived just to prove that it could be done. So after all of that, what did we end up with? So this is a bit of a microsystem view of some of the slides that you saw this morning. So this is what we did over 10 months, getting about 200 providers up and running on our EHR, which translated into approximately 20,000 monthly prescriptions going out of our system. And actually, it was very interesting because we were looking at statewide data at the same time, and if you looked at San Mateo County, it had the same trend during this time. And so we were very proud to be, at least in our own minds, a driver of that process. So this is actually very interesting and important, and the volumes and the impact are also important, but it fails to address one simple thing, which is it's all about me. And what did this do for me? And when I'm in with a patient, what do I see? So this is what I see, what I get to see now, which is an integrated medication list there on the left. Allergies that crossed our entire system so that everyone has the same amount of information, and at least the opportunity to, in the future, use this for clinical decision support. So I think it would be disingenuous to end the story there. There are still challenges ahead of us, and these are some of the challenges that we look forward to addressing in the next few months. The first two are internal to us, looking at formulary functionality. It's there, but for a variety of technical reasons, it does not serve us as well as we would like. I think something that's very common is the whole issue of drug interaction fatigue. Screens that pop at you multiple times telling you things that you learned in med school were no longer true, and trying to adjust those levels down. I think that multi-vendor issues are a very complex situation. Whenever there's a situation where information passes from vendor to vendor to vendor, it's very easy for one to think that the other is responsible for any issues you might have, and it becomes up to the end users to navigate that. Data availability. Coming from a QI background, it's very hard for me when data is not readily available. And I think that the more transparent data becomes, the easier it will be for us to push this process forward. Faxed refill requests. So this is one of those things that irritates you in hindsight, that lots of people knew that turning on new prescriptions was different than turning on refill prescriptions, and that many pharmacies have not quite gotten to the point of turning on their refill functionality yet. This creates a lot of workflow issues within the clinic. And then lastly, when you have providers who have multiple sites, there are challenges in terms of getting refill requests for their patients in your facility and vice versa. However, I understand that in the next SureScripts upgrade that this will be addressed, so I'm very much looking forward to that. So thank you very much.